As part of the training program, we are regularly running discussion for MR Pagur Hospital. So it will be an audit for month of August for all 3 units at MR Bangalore Hospital. The first person will be by Dr. Deeptiman Nundi, is a second year junior resident at Internal General Surgery at MR Bangalore Hospital. So Deeptiman, share your screen and present. Please.
One general surgical audit of MR Bangalore Hospital, August 2023. Total OPD days 9, total admissions 10, 11, total OPD presence about 1700. Number of elective OT days 9, total time in OT, lab 16 hours, and open table about 23 hours. Total number of minor OTs 11, minor OTs 17 and 25 minutes, and emergency OT 3 hours. Number of mortalities 2. Elective admission about 62, emergency admission 9, elective operation 36, emergency operation 4, minor operation 42, mortality 2, and morbidity 2. In the hepatobiliary and pancreatic splenic surgery sections, chronic calculus cholecystitis were total cholecystitis. In one case, it was lab converted to open cholecystectomy. In the gastrointestinal and perianal section, 2 cases of fistula in ano who underwent fistulectomy and 1 case of recurrent appendicitis who underwent appendicectomy. This was an open appendicectomy. In the hernia and groin surgery section, 1 case of hematocele undergoes evacuation of hematoma of total sac. Congenital hernia, it underwent inguinal herniotomy. 1 case of umbilical hernia underwent mesh hernioplasty. There were 5 cases of Lichtenstein mesh hernioplasty and 2 cases of phimosis which underwent circumcision. In other miscellaneous sections, 7 cases of diabetic foot which underwent debridement, 1 case of Baker cyst underwent excision, and 1 case of fibroadenoma right breast which underwent excision. Emergency admissions were about 9, including 1 case. Just 2 cases of morbidity and 2 cases of mortality. In the morbidity section, morbidity first case, a middle-aged female underwent lap cholecystectomy due to calculus cholecystitis. Interrupt, there was dense peritoneal adhesion. Since POD1, she started having biliary secretions in the den. Total count within normal range, no incidence of fever of jaundice. She was kept on NPM with IV fluids and other supportive management for the coming few days. Biliary drainage continued about 80 to 100 ml per day for the next 5 to 6 days. Since POD8, the drainage secretion started to decrease and it became almost nil in the next 5 days. We are now planning to discharge the patient. Another case of morbidity. This is a case of cellulitis in leg with uncontrolled diabetes, got admitted in the surgical ward. Debridement and dressing was done. However, there was continued wound discharge from the next day. Dressing continued along with other conservative management. After a few days of dressing and conservative management, the discharge wound showed some sign of improvement. He was then put into back therapy machine. He is still in the ward and we are planning to discharge him soon. Now, this is a case of first mortality in which an elderly male with head injury was admitted. NCCT brain revealed huge subdural hemorrhage. Patient was initially referred to a neurosurgical center, but the patient party refused our proposal. They insisted that we keep the patient in this hospital only, but we are not having any neurosurgical facility here. He was admitted in the ward instantly with very low GCS and extremely morbid conditions, including low BP, tachycardia, and tachypnea. We tried to resuscitate in the ward, but he ultimately succumbed after some time. Next case of mortality. This was an elderly male admitted during night time of our admission day with wound infection in the leg, uncontrolled diabetes, fever, minimal urine output, and disorientation. He was given conservative management and dressing was done on the wound side. However, in the next few hours, he developed tachypnea, tachycardia, very low BP, and renal shutdown. Although we tried to shift the patient to CCU, but bed was not available at that moment, we continued therapeutic support in the ward as much as possible, but he succumbed within next few hours.
Done?
Yes, sir. Done.
What was the reason for lap chole conversion to open? What was the problem?
Sir, it was there was
It was a routine or it is lap chole for acute cholecystitis?
no, sir, it was a lap chole.
It was not in acute phase.
No, not in acute phase.
So admission could not be lysed.
No, admission could not be lysed.
So in morbidity 2, just go to morbidity 2. What is this in morbidity 2? Morbidity covered. Wound infections, other complications. The first case was all right. Patient has excessive biliary drainage. This is the usual sequence of a patient has got a diabetic foot infection. You did debridement, and then there was discharge, you apply back, he recovered well. Is it morbidity? Try to understand why I like to discuss in morbidity. In out of 36 patients, no patient has wound-related complications in 1 month. You are not observing.
Yeah,
You have operated 36 elective and around 9 emergency operations. None of the patient has any complication, wound-related complications, pulmonary complications.
Sir, among the emergency, sir, there were a good number of these debridement cases. So.
Debridement cases, patient may have more dead tissue, may require repeated debridement. That is not a morbidity. What I'm trying to say is morbidity is some deviation from usual post-op recovery. And regarding the subdural hematoma, when did you diagnose this? In emergency, in ER, before the patient admitted or after admission?
Sir, patient came to ER, then some initial support, we asked the patient to
No,
go for
ER patient came with the CT?
No. CT was...
When is the CT done?
Sir, after coming to...
What?
No.
Or in ER?
ER.
So if ER patient got a subdural hematoma, significant subdural hematoma, how was the counseling then? I don't understand. No patient party wants the patient to die. Once the patient has got a significant subdural hematoma, it was the duty of the surgical resident or whoever on duty to convince the patient that this patient can be saved and he needs to be in a new cell center. But this cannot be just a casual statement. Patient party refused. Why this?
Because the patient party felt that it will be not possible for them to take to...
Then the hospital take the responsibility. You cannot kill a patient. When you are documenting patient has got a significant subdural hematoma, just because patient party, we cannot take the patient, you could have provided an ambulance service. You got my point. They may be in a problem with it. They came to MR Bangu, so they came for some treatment. If we cannot afford to take the patient to trauma center or center, it will be duty of the hospital. So was the authority informed that this patient needs immediate neuroscience intervention? Who counsel? You counsel? No.
Yes, I talked to the patient party.
What did you talk? Which people came with the patient? What was the age of the patient?
So it was around 20 plus.
Okay, but everyone has the right to leave.
The patient body says that they have taken previously to other centers. Now we have come to here. Please admit.
No, where they have taken? Then CT was there.
The CT was.
How can it be? They have gone to other centers and now they don't have a CT scan. Is unbelievable.
Not a higher centers, sir. Small centers.
No, this is a casual statement. I don't agree to this statement that elective elective operation में जाकर next no other GI case admitted.
No, sir, because we are having staff short in the month of August, so very minimum cases.
Staff short? Why? You have house staff. You are there. Ronit is there.
No, Ronit was not there in August. And
okay.
First second.
Chalo, come on. Please present next. Yes. So the next presentation will be by Dr. Mehul Patel, who will be presenting the surgical audit for Unit 2 General Surgery.
There's a lot of interference. That the station.
So administration doesn't want to see the patient.
No, the patient who does not need surgery, I'm not talking to that patient. Patient who need immediate surgery, somebody has to take the responsibility.
So it very often happens that this administrative people ask them to please admit, we don't treat.
Sorry, you have to convince him this patient needs surgery. Why don't you admit a patient who is not having a complete hematoma? You have to admit the patient. All head injury patients not go to the health center. Don't blame admission all the time. These are patients where you should have convinced the people that this patient needs some surgical intervention. He may have been saved. I'm not convinced that admin will tell you admit the patient and kill him. Then let me know. Patient does not require surgery. Why should be health center? What is the treatment?
Good morning, everyone. I'm Dr. Mehul Patel. I'll be presenting surgical audit for the month of August for Unit 2 General Surgery. Total number of OPDs.
The first slide is not on outpatient surgery. Change it. It is a summary of the whole event. Total number of admission days, total number of emergency days, total patients in the OPD, total number of surgery done. This is a brief overview. Mortality, morbidity. First slide is that only. Why do you suddenly start changing? You see the last month.
Total number of elective days, elective OT days 8, total time in OT plan in lab is 38 hours 50 minutes, in open 24 hours 40 minutes. Total number of minor OT days is 9, time spent in minor OT 10 hours 40 minutes, number of mortalities 1, number of morbidities 1. Total elective admissions 42, total emergencies admission 29, total elective operations 34, total emergency operations 17, minor operations 22, mortality 1 and morbidity 1. In hepatobiliary and pancreatic and splenic surgeries, for chronic calculus cholecystectomy, 14 laparoscopic cholecystectomy was done. For one case of chronic calculus cholecystectomy, open cholecystectomy was done. In gastrointestinal and perineal surgeries, one case of anal fissure, lateral anal internal sphincterectomy was done. One case of internal hemorrhoids, hemorrhoidectomy was done. One case of rectal prolapse, CS procedure was done. One case of recurrent appendicitis, open appendectomy was done. And 2 cases of recurrent appendicitis, laparoscopic appendectomy was done. In hernia and groin surgeries, 5 cases of inguinal hernia for which herniorrhaphy was done. 1 case of umbilical hernia for which anatomical repair was done. 1 case of incisional hernia for which open mesh repair was done. 1 case of one case of hydrocele for which Jabulis procedure was done, and 2 cases of phimosis for which circumcision was done. In breast and endocrine surgeries, the 3 cases of breast fibroadenoma for which excision was done. In emergency operations, for a case of peptic perforation, exfoliatory epidomy with Graham's patch tibia was done. For a case of appendicular perforation, exfoliatory epidomy with appendectomy was done. For one case of venous gangrene, debridement was done. For a case of foot ulcer, debridement was done. For 3 cases of gluteal abscess, incision and drainage was done. One case of supraclavicular abscess, incision and drainage was done. And for one case of breast abscess, incision and drainage was done. For a case of 2 cases of acute gallstone pancreatitis were conservatively managed. 2 cases of acute alcoholic pancreatitis were conservatively managed. 1 case of acute calculus cholecystitis was also conservatively managed, and 2 cases of subacute intestine obstruction was also conservatively managed. For 5 cases of foot cellulitis, conservative management was done, and for 6 cases of diabetic foot ulcer, debridement and dressing was done. Total 22 minor operations were done, and 1 chest incision was performed. 1 mortality and 1 morbidity. Morbidity 1, a 24-year-old gentleman presented in the ER with tenderness in the right with the raised temperature and tachycardia. On examination, lump was palpable. CCT was done, which suggested the base of the appendix. Appendectomy was done. Drain was placed in the pelvis and abdomen was closed in layers. On POD2, there was pus discharge from the wound side, and sutures were removed, and daily dressing was done. The patient recovered uneventfully and the discharge was gradually reduced by POD7. The patient was discharged on POD9. Mortality 1, 80-year-old lady presented in the ER with respiratory distress and right foot cellulitis with a ruptured abscess. Non-diabetic and hypertensive. CBG on presentation was 155. ID was done. She was given high dose antibiotic therapy, moist O2 inhalation, and nebulization with urine Budecort. On POD1, her count came out to be 34,000, and she was in tachy and had high grade fever. On POD2, her respiratory distress increased with fall in blood pressure and metabolic acidosis. She was immediately shifted to CCU, where fluid resuscitation along with noradrenaline support was given and acidosis was being corrected. She was intubated on POD6 due to respiratory distress, but she succumbed to death in the same evening. Thank you.
What about that with years? What was the patient profile?
So she was a 85-year-old female presented in.
She was unfit for rectopexy.
And we performed tears on the next day. Next time.
And you have operated 3 cases of fibroadenomas.
Yes.
It's conservative only. Why? How do you select patient for the best? You should think twice before you jump onto exercise for a young lady.
Program is actually working very good.
Very good. 95% response rate. I hardly operate patient for fibroadenomas.
I think that we have not done fibroadenoma last 6 or 7 months.
Yeah. Mobility is 0. 1 appendectomy, 1 infection. But I'm trying to say is, come up with the situation in your ward. What is happening? That is how you make an audit. Audit is to what? Find the gap and then discuss how to mend the gap. So you are not doing anything. You just at the end of the month you present, they have no mobility. How can it be? You are doing 50 operations in a month and 50 operations gone smooth. It cannot be. It doesn't happen. Prosenjit? The next presentation will be by Dr. Prosenjit Basu, who is a second year junior resident at Audit for Unit 3 General Surgery.
Good morning, respected teachers. I'm going to present a surgical audit for the month of August 2023 for Unit 3, which is under Dr. Emil Shah, Dr. Evomik, and Dr. Ishesh Mishra. Here is outpatient summary. Total OPD days 9, total admission day 10, total OPD patient 978, which includes new patient 694 and old patient 284. Total number of elective OT days 8, total time in OT plan lab 1 38 hours 10 minutes and open tables 32 hours 15 minutes. Total number of minor OT days 10, total time in minor OT 17 hours 25 minutes, time in emergency OT 3 hours. Total number of mortality 1 and 2. A summary of August 23 elective admission we have 62, emergency admission 9, elective operation 50, emergency operation 3, minor operation 47, mortality 1 and morbidity 2. Elective admissions, hepatobiliary and pancreatic spring surgeries, chronic calculus cholecystitis. For 21 cases, we did laparoscopic cholecystectomy. One case, we have chronic calculus cholecystectomy with cholecystocolic fistula, in which we started with lap cholecystectomy, then we have to converted it into open cholecystectomy. A case with chronic calculus cholecystectomy, we did laparoscopic cholecystectomy with dilation. One case of periampullary carcinoma, we did Whipple's pancreatoduodenectomy. One case of carcinoma of head of pancreas, we did for gastrointestinal and perianal cases. For recurrent appendicitis, we did laparoscopic appendicectomy for 2 cases, and for 1 cases we did open appendicectomy. For fistula, we did fistulectomy for 5 cases. For hernia and groin surgery, bilateral inguinal hernia, we did TAPP. For 2 cases, 2 bilateral cases, we did TAPP, and for single unilateral cases, we did TAPP for single case. For incisional hernia, we did IPOM plus for 1 case. We did Liechtenstein mesh hernioplasty for single cases in a case of bilateral inguinal hernia. In 2 cases of unilateral, we did Liechtenstein mesh hernioplasty. Umbilical hernia, we did mesh hernioplasty. And for a single case, we did mesh hernioplasty at retrograde spleen in ventral hernia. We did circumcision in 4 cases of phimosis. Oh, sorry. Previous slide. For breast and endocrine, for a single case in which cystic lesion is present in the right breast in the left in the lower inner quadrant, we did excision. For colloid goiter, we did left-sided hemithyroidectomy for single case. For miscellaneous, a sinus tract excision done in right elbow, and for diabetic foot with digangrene, we did below amputation. For emergency OT, we did loop ileostomy for acute intestinal obstruction in a case of CA colon, and we did 2 ID for a perianal cases. There are a few emergency cases are managed conservatively, like acute pancreatitis for 1 case, acute calculus cholecystitis 4 case, and left foot cellulitis with type 2 DM and hypertension, and diabetic for 3 cases. Minor operation and emergency intervention, some charts are there. Morbidity, we have 2 cases, and mortality single case. Morbidity 1, a 45-year male admitted with provisional diagnosis of chronic calculus cholecystitis associated with neuropsychiatric disorder undergo lap cholecystectomy, which is converted to open cholecystectomy as there is intraoperative finding of cholecystocolic fistula. and presence of frozen scallops and dense adhesion. Patient doing well up to POD3, then he develops wound infection, which is managed conservatively. Wound absent for culture sensitivity, which comes out to be positive for Klebsiella and sensitive for doxycycline. After successful conservative management on POD7, secondary suturing done and patient discharged on POD9. For morbidity, second case, 42-year female admitted with provisional diagnosis of chronic calculous cholecystitis. We planned lab cholecystectomy. Patient undergoes lab cholecystectomy. There is intraoperative bile duct injury, which is repaired intraoperatively with 30 PDS laparoscopically. POD1 patient is complaining of pain in epigastric region, which is episodic with episodic nausea and vomiting, with drain content of 50 ml, which is bilious in nature. On POD3, content reduced to less than 25 ml, bilious content. POD3 patient respond well with conservative management, soft diet allowed. On POD4, we did a USG. It shows no intra-abdominal collection. On POD5, patient discharge after successful conservative management. Single mortality case, a 65-year-old male is presented with features of obstructive jaundice and with provisional diagnosis of carcinoma of head of pancreas. After initial optimization of patient, Whipple pancreaticoduodenectomy planned, but intraoperatively it comes out to be unresectable. So it is converted into palliative procedure, that is triple bypass surgery. On POD0, patient is shifted to CCU as there is persistent hypoxia post-operatively. On POD1, room air trial given, but it fails. The urine output also decreases to less than 50 ml over 12 hours. The drain output is 300 ml, serosanguineous. POD2, patient develops features of shock and anuria. Hemodialysis planned, but patients develop cardiac arrest. Research is tried as per ACLS guideline, but ROC cannot be achieved and patients come to death.
What do you think what has gone wrong with this patient? This is a patient of obstructive jaundice for a major item. Could you analyze this patient?
Yes, sir.
Patient has hypoxia, patient has renal shutdown.
Sir, it is in shock. Patient is in
Patient shock.
which cannot be resuscitated.
What happens in a patient of obstructive jaundice in the post-op period if it is not properly optimized? Is a classic case of hepatorenal failure.
Yes, sir.
And one important cause is dehydration. Second is sepsis.
Sepsis.
So it might be that not optimized properly, patient probably are not properly hydrated. Why he should have POD1? He has gone to renal shutdown.
Yes, sir. Optimization will be better if
Go back. What you said? One patient intra-bile duct injury. How could you diagnose the intraoperative bile duct injury on table?
so
what is the problem?
bile leak is present.
When did you find the bile leak? While dissecting, you find the bile leak, or after completing the procedure?
After sir, clipping the cystic duct.
Was there any difficulty in dissecting the callops?
The callops is frozen and
Callops was frozen.
yes, and there is adhesion of momentum in the.
So what was planned? If the callops was frozen, you cannot persist dissecting the callops area. Was a different approach taken, or you try to dissect the frozen callops?
So frozen callops.
But that what should not be done. If you have a frozen callops,
yes, sir,
then the procedure has to be a different approach. Frozen callops, it is no point keep on persisting the callops. You have to go to the meat body. Calm down. If need be, one should have a bailout procedure. What is bailout procedure? What is bailout in a difficult situation? Bailout is subtotal cholecystectomy. If the callops is frozen, keep in mind that if the callops is frozen, you are not understanding where is the CBD, where is the cystic duct, where is the artery. So if you keep on doing the frozen callops, you will be in problem. In that case, either you can go to fundus first, but fundus first also is not a good technique for preventing bile duct injury. what you can do, you can start this in the mid body, away from the calories. Dissect, try to go down to the point you can go. And if all is frozen, open the gallbladder near the neck, empty the stones, and just overrun it. Okay, but
Yes.
you see, you already predicted that there's a difficult calories, and you persisted to dissect in that area. That result in this injury. This injury, patient is lucky that patient has recovered in about 2-3 days time.
Yes.
Dr. Kaur, anything to comment?
Hello, can you hear me?
Yes, Dr.
Hello.
Kaur. Yes.
Hello, yes, you can hear me. He said, Bhushanji said that in your unit, you started a planned laparoscopic cholecystectomy, but that was converted into an open cholecystectomy because there was a cholecystocolic fistula, right? Now, regarding the open surgery, I want to know, gallbladder was taken care of, cholecystectomy was done. What about the colic fistula? How did you manage the colic fistula?
What was done?
So it is repaired.
It was repaired with PDS suture.
PDS suture.
It was repaired with interrupted PDS suture.
So
There was no leakage.
in this case, you went for a primary repair of the colic part,
Yes, yes.
that is the colic
Yes, sir, yes,
fistula.
Yes.
You
yes.
didn't do a colostomy through that opening,
No.
but the bowel was unprepared in this case. So I think it would have been better if you had gone for a colostomy.
No,
Because
sir,
the
it
bowel was-
very
No,
small.
sir. Dr. Kaur, now that
Patient was
Dr. Kaur, now
Yes,
that
please.
now you see, you come to the gut
Yes.
record. In left colon, there are
Yes.
people who are venturing to go ahead without any gut preparation. So it's not mandatory to prepare the right colon, because right colon more often is not loaded with stool.
Okay.
So right colon you can go with. It's not necessary to, unless you have a very
So-
large rent in the colon. And
Okay.
if cross contamination and you have a large rent in the colon, it will be safe to do a colostomy. I agree. But if you have a most of the time this cholecystocolic fistula, the technique should be you take a sleeve of gallbladder wall rather than dividing the junction of colon with the gallbladder itself. So
Yes.
sleeve of gallbladder wall and then
Okay.
repair it. So there will be not much of contamination.
Thank you. Thank you so much.
Thank you. Okay. Thank you.
Thank you, sir.